I remember Giardia as a very funny parasite. It's got a lot of flagella. It's got two big eyes. That is the binucleate cyst. And that is the infective stage. So I remember Giardia as an old man. Okay. And I remember it as an old man because it's been around since a long time. Okay. And secondly, it causes a very chronic, long GI symptoms that are usually gone unnoticed as well. Okay. So I think Giardia coli, Giardia, okay, is a very important mastigophora. It's a very important mastigophora of the Sarcomastigophora phylum. As you know, I spoke about parasites being of Sarcomastigophora phylum, and Sarcomastigophora is divided into Sarcodina and Mastigophora. It's Mastigophora and Sarcodina. Sarcodina is Entamoeba histolytica, and Mastigophora is Giardia. Correct. So it is the most common. Why do I call it the grand old man? Because it's been the most common cause of parasitic infection in the world. Okay, and it is found in the lumen of small intestine. Now that's a differentiating factor, is because E. histolytica was found in cecum colon. Okay. It chlorination, nothing affects it. Patient at risk if you have an IgA deficiency, if you have decreased gamma globulins, or if you have a chronic variable immunodeficiency disorder, CVID. What is the infective form? Quadrinucleate cyst. What about the disease causing form? That's the trophozoite, as I told you. And the trophozoite is pear shaped. It's pear shaped. Okay. So it's dorsal convex and ventrally concave. So this is how it looks like, the trophozoite. Now let's talk a little bit about the quadrinucleate cyst, and then let's get into the trophozoite as well. Okay. So when you ingest the quadrinucleate cyst, you ingest it. Okay. It reaches the small intestine and it excistation occurs. And its excistation is actually occurring in the duodenum. Okay. So it's excistation in the duodenum. Once it is existed in the duodenum, it reaches the trophozoite, and in trophozoite it emerges and develops. And in trophozoite, what it does is that the trophozoite, which is the pear-shaped trophozoite, it attaches to the GI mucosa. Okay, so if this is the GI, it attaches to the GI mucosa. And what does it cause? Does it cause nibbling, anything of that sort? Well, actually, it's a non-invasive diarrhea. So they just adhere here. Okay, they just adhere. Let's say it's red in color. So they'll adhere here. Adherence. And once they adhere, they are just going to cause apoptosis of the enterocyte. Okay. And see, because it's in the small intestine, obviously villi are going to be present. So there's going to be loss of the villus character of the small intestine. So the villi are lost. And because the villi are lost, also the enzymes like disaccharidase is lost. Disaccharidase. You know what is disaccharidase? Disaccharidase is an enzyme that converts larger glucose molecules into glucose or fructose into glucose sucrose and stuff like that, just into smaller molecules. Okay. So disaccharidase enzyme is lost. Okay. So what happens? So because of that, a lot of the glucose that is present, there's a lot of lactose intolerance, because lactose that is entering is lost. Okay, so lactose intolerance does occur because disaccharidase also means that lactase is gone. The enzyme lactase is gone. Okay, so that means lactose cannot be converted into glucose galactose. And when it's not converted into glucose galactose, that means lactose is directly passing into the GI and it's causing lactose intolerance. So this is one of those causes that's an acquired cause of lactose intolerance. And what also it does is that these trophozoites, because they cause adherence, they also disrupt. They also disrupt the tight junctions. So when they disrupt the tight junction, there is increased in secretion, and there's going to be again diarrhea. So this entire system of events that are occurring, they occur within, let's say if there is an infection, if you've ingested the cordinucleate cyst, and there has to be an incubation period of 1 to 3 weeks. And then the patient is going to come to you with features of diarrhea, flatulence, abdominal pain, okay, malabsorption, and then malabsorption of steatorrhea, loss of weight, etc., etc., etc. So when I say malabsorption, there can be so many symptoms that the patient can present as. So then, if let's say this is not treated, it gets into a chronic stage. Okay. So what happens is that there are recurrent episodes. Okay. And these recurrent episodes are also associated with a lot of complications like urticaria, arthritis, salt pepper retinal changes, uveitis, salt pepper retinal changes. So all of these actually that occur, okay, they are complications of chronic giardia because of the inflammatory response. Now giardia actually, it has a very important antigen variation. Okay, it has a variant surface protein that actually causes change in the antigen recurrently. Okay, it has a cysteine rich protein which is called variant surface protein. And because of these changes in the antigen, okay, a lot of these giardia on chronic infection goes unnoticed. Okay, so that's very important. Now when I look at the trophozoite, okay, the trophozoite that we saw, the trophozoitic stage, it is a pear-shaped stage. So when I'm looking at the side, it's something like this: dorsal convex, ventral concave. Now I'm looking at from the top part. Okay, so it has 4 pairs of flagella: 1 2 3 4, 1 2 3 4, and it has 2 nuclei. Okay, it also has a suckling disc. As I told you, I find this giardia as a very dangerous Halloween costume. So this is what I'm saying. The motility is going to be leaf falling motility. So whenever you see the motility, it's going to be as if this is going to be the motility pattern. If this is the point of giardia, it's going to go like this. Okay, so in white. Okay, this is how the leaf falls. Okay, so very it's gliding through basically. So how do you want to diagnose it? You just diagnose it by stool. Take 3 stool samples, do a saline iodine mount. Why do you do a saline iodine mount? Because you want to visualize it, you want to concentrate it. You can do a formol ether sedimentation. So you do the sedimentation techniques, and on the mount you see trophozoite plus you see the cyst. What else you can do is you can do ELISA and you can check for copro antigen, or you could do your PCR, which is your gold standard. Okay. Again, serology you don't want to do. You could do a very important test called entero test or string test. So basically, you take a string and you put it inside, and there is a biopsy taken with the string, and then again you remove it. Okay, and then you see the biopsy or the aspirate or sample. You can also do the ICT test. ICT test again uses the ELISA, and as I told you, there are 3 pathogens: E. histolytica, yes; cryptosporidium, yes; and giardia. Correct. Also, you could do X-ray barium meals, but again, that's not diagnostic. So how do you want to treat it? Drug of choice. What do you do? Metro. By metro, I mean metronidazole. And also you do tiny metro. So tinidazole. I remember Giardia being a man who needs a tiny metro. Grand old man with a tiny metro. Simple. So this is about Giardia. Now let's jump right into a very important disease. Okay. The very important disease that I want to speak about is cryptosporidia. But before that, there's one more parasite, a small one rather, called Balantidium coli. It causes what it causes. I'm just naming the very important facts about this. Okay, the host is the large intestine of pig or human, any. Infection is ingestion of stools. The infective form is going to be a binucleate cyst. Up till now, we saw both the infective forms were quadrinucleate, and the pathogenic form is going to be the trophozoite. A very important thing about the trophozoite here is that does not have any flagella. It has a cilia, and it also has something called as a cytopage. Okay. It has two nucleuses, micronucleus and macronucleus. So when I look at the trophozoite, it's something like this. It has a cilia, it has a macronucleus, it has a micronucleus, it has a food vacuole, and it has a indentation called as cytopage, or however you want to call it. I'm just saying it because there can be a good enough chance that can be a question. What can it cause? It can just cause a very important thing. It can cause dysentery. What's dysentery? Ciliate dysentery, because it's a cilia parasite. So you'll have bloody stools. You want to treat it. How do you treat it? You treat it by a tetracycline. How do I remember Balantidium coli? Balantidium is first of all affecting the coli. Okay, it's cilia, because both parasite that we saw were either flagella or pseudopods. So now it's cilia. And the very important thing is that it causes dysentery. See, usually okay, most of the disorders that affect the colon can lead to dysentery. Most of them. For instance, Shigella. For instance, Entamoeba histolytica. They can lead to dysentery. But Entamoeba leads to dysentery later, not directly. So I have covered Balantidium coli as well in this particular module. Now let's look at the much awaited third parasite of the ICT group, that's the cryptosporidium. Now cryptosporidium, it's a coccidian parasite. It's amotile. Okay, it's immotile. Motility is 0. Because it's from the apicomplexa. And apicomplexa, as I told you, is the immotile part. Is the immotile phylum. Okay. It causes a lot of diarrhea in an HIV patient. So if you get a clinical vignette where there's a HIV patient with recurrent diarrhea, you want to think of two things. You could think of Giardia, or you could think of cryptosporidium, and then you have to look what hints they are giving. What hints they are giving to further solidify your investigation or your diagnosis. So in cryptosporidium is one of the parasites or protozoans of the coccidian group. So let's just look at the other parasites of the coccidian. One is the cryptosporidium that we want to talk about right now. Other is the cryptoisospora. And the last is the cycloisospora. Cryptosporidium, cryptoisospora, cycloisospora. Now what is the mode of infection? Mode of infection is auto-infection, or again contact with feces. Auto-infection, feces contact. stuff like that. And it's a zoonosis. That means this has to be present in some other organism as well. Correct. So it's a zoonosis, but it can definitely reach the human as well. So let's just talk about what kind of a doses does it need. Infective dose is really small, but the in spite of infective dose being small, we usually, normal people are not affected because we have an intact immune system. But what happens is that in HIV patient, it's usually compromised. So that's why a small infective dose can lead to recurrent diarrhea. And hepatitis, you have to have a small intestinal mucosa. Now, because I'm saying small intestinal mucosa, I think it's very clear, it's very subtle that there's going to be diarrhea. Correct? There's small intestine is infected. But what happens is that even in infection of small intestine, they do not enter. They form something called as an extracytoplasmic vacuole. Okay, so there's an extracytoplasmic vacuole that is formed, and they usually reside in this extracytoplasmic vacuole. They do not enter. Correct. So then definitely there's only one host. Okay, there's only one host, and the host is single, but it can be single. It can be human. It can be cat, cow, whatever. And the ingestion is what do you ingest? You ingest a small dose of oocytes, okay, with contaminated food or water, with the feces. They have been released into the feces. So there has to be sporulated oocyst. Okay. Now see, this is, as I told you, there was cyst and trophozoites in the other parasites. But now we are talking about oocyst and the sporozoites. Okay. So what happens is that there is an oocyst. Okay. So oocyst contains sporozoites, ideally. So when they are ingested, and if they are sporulated, okay, there are two types. There is one is an unsporulated, there is a sporulated. Okay. So the sporulated oocyst, when they are ingested, okay, in the intestine they exist and they form sporozoites. And in the sporozoid, what they do is that the sporozoids, okay, they become something called as trophozoites and merozoites. Okay. So first the sporozoites are formed, then the sporozoites invade mucosa. And how they invade, as I told you, they form an extracytoplasmic vacuole. Okay. And once they are inside the mucosa, first they form trophozoite or they form a merozoite. Okay. And then they lyse the enterocyte and infect the next enterocyte. Okay. Now, mind you, this is a very important point that I'm trying to make, is that this is a life cycle for cystoisospora or cyclospora. Now, this vacuole thing that I told you, extracytoplasmic vacuole, is something that's seen only, that means only and only cryptosporidium, not cryptoisospora, cryptosporidium. But here we are seeing the life cycle of isospora, and cycloisospora. So here there is no trophozoite extracytoplasmic vacuole. Here the mucosal trophozoites are formed, okay, and they form merozoite 1, and then they invade and they enter the next, and so on and so forth till they become merozoite 2. When they become merozoite 2, they become micro and macro gametes, and then they fuse macro and macro, and then they fuse to form oocyst, but unsporulated. Now they have to undergo sporulation. So do they undergo sporulation outside? Yes, they undergo sporulation. So they are usually, when we see feces, they excreted is unsporulated. Correct. But when I'm talking about cryptosporidium, this is very similar to that of a malarial also as well. Micro and macro gametes, merozoites, and stuff like that. Again, it's very similar, but it's not exactly the same. Okay. So let's talk about cryptosporidium life cycle. Cryptosporidium. Crypt means they are making an extra cytoplasmic vacuole. Cryptosporidium. Again, simple. You ingest the sporulated sporulated vacuole or sporulated oocyst. You've ingested the sporulated oocyst, exgestation has occurred, sporozoites released, sporozoid enterocytes invaded enterocytes invaded, and then when you invade the enterocyte, you have a merozoite 1. Merozoite 1 is going to get forming a extra cytoplasmic vacuole, then it forms a merozoite 2. Obviously the entire cycle has to remain pretty much the same, but what is different is that they form micro and macro gametes too. Micro and micro gametes, they fuse, okay, they fuse, and they do not form unsporulated, they go and they form sporulated oocyst. And now the sporulated oocysts, some of the sporulated oocysts themselves remain inside the GI mucosa, and via retrograde or autoinfection or retrograde, they reach here, okay, or they can be excreted. Now the difference is that here there cannot be any retrograde because there are unsporulated oocytes, okay. Here in a cryptoisospora or a cycloisospora, there are unsporulated oocytes, and unsporulated oocytes mind you, cannot give rise to a sporocyte unless they are sporulated. And for sporulation is external environment. So having a sporulation in the external environment is so important to prevent autoinfection. But here this organism itself does not need external sporulation, therefore it can directly sporulate inside the intestine and they can give autoinfection. Clinical features: simple lysis of enterocytes, as I've told you, lysis of enterocytes. And because there's lysis of enterocytes, there's going to be watery diarrhea, abdominal cramps, water diarrhea, abdominal cramps, low grade fever. Okay, and in HIV patients, obviously there's unrelenting diarrhea, so much of diarrhea. How do you want to diagnose this, dude? Like, if you want to diagnose it, you do simple. You do stool, prepare wet mom, and you check, or you do a sedimentation technique, or you can also do your flotation technique. Okay, you can also do your flotation technique, and you just view what is there, or you do your stool, okay, and then you stain it. Very important is that you stain the stool. Now when you stain the stool, what do you use? Okay, if you remember, you have to use a ZN stain, modified, obviously, with a lesser acid fast, because they're partially acid fast. And what you see is that you can see microscopically, okay, you make a differentiation between the three types of coccidian parasites that we know. First is your cyclospora, then you have the cryptosporidium, or let's say we have the cystoisospora, and then you have the cryptosporidium. Okay, so looking at the cyclospora and cyclospora and cryptoisospora, cystoisospora, they both have unsporulated oocyst. That's something that we understood directly from the life cycle. And this will have the sporulated. Cryptosporidium will have the sporulated oocyst. Cryptosporidium, sporulated oocyst. Nice. Cryptosporidium. Now let me talk to you about this very important case of cyclospora and the different sporulated stage that we can see. Correct? Because the unsporulated stage in cyclospora, the unsporulated stage will become the sporulated stage in 7 to 15 days in the external environment. But for the cystoisospora, okay, they mature to form sporulated stage, okay, but it's not seen on microscopy. Okay, so what do you mean? What I mean is, they do mature to form the sporulated stage, but you cannot identify it on the microscopy, okay, in the external environment. They both need like approximately 7 to 15 days, approximate. Now when you've given it the external environment, okay, you have to check the sporulated stage to differentiate between these two, okay. That is the cycloisospora and cystoisosporidium. First, you have to check how many, in the sporulated stage, how many sporozoites or how many sporocysts are present. If it's two, it's cycloisospora. Two sporocytes in two sporocyst. So sporocyst is this big cyst, and inside that there are two sporozoites. But when it comes for the cryptoisosporidium or isospora, in the cystoisospora, it's going to be two sporocysts, and there are going to be 1 2 3 4 1 2 3 4 in each sporozoites. So it's going to be 2 into 4. Here it's going to be 2 into 2. Like this you can differentiate. Okay. Second is the much awaited, the more common one and the more frequently questioned upon is the cryptosporidium. They have sporulated oocysts, and the oocysts are seen without any sporozoites. They just contain the without any sporocysts. They contain 4 sporozoites. 4 into 1. Okay. What else can you do? You can obviously do the ICT that I've spoken about, triage panel set. You could do PCR. You can do antigen detection. And serology again you don't do. Now if you want to treat this patient, you have a patient, okay, and usually he's going to be cryptosporidium only. So what do? You do nitazoxanide. Okay. Also you can give macrolides. Okay. But what about the other species? The other species you have to give a crotrimazole. The other two. Usually the other two are given together. They are given as crotrimazole. Can you give for cryptosporidium as well crotrimazole? I think yes you can. Okay. I think yes you can. Very high chance. Okay. So I think that is about it when it comes to all the protozoas. Now next lecture we will look at the different helminths that can cause diarrhea.